As mentioned, welcome everyone, and this is our event, The Future of Medicine in Africa. So to begin, the first portion I guess I need to highlight is this event has been made possible through One Day Sooner, and of course this event is being launched by the One Day Sooner, the African chapter. One Day Sooner is an international non-profit organization that advocates for people who want to participate in high-impact medical trials. That includes COVID-19 challenge trials. And the African chapter of One Day Sooner is a non-profit entity that works to implement strategic goals of One Day Sooner that are applicable to the unique context of the African continent. And additionally, the African chapter, due to the peculiar landscape of the African continent, also aims to promote medical and scientific research because these have been noted to be in a way lagging. Then also highlighting this is the many challenges in Africa with regard to our healthcare systems have only been made worse by the coronavirus pandemic, and in part have highlighted some of the already existing weaknesses in our long-term policies and approaches. And in a way also they have invoked an awakening for the need for future pandemic preparedness on the continent. And for those of you who are joining from the African continent with widespread misinformation, conspiracy theories, the lack of medical breakthroughs, inadequate health reporting systems, and the absence of investment in research and development, these all have resulted in a situation of vaccine hesitancy and mistrust of Western therapeutics. While little can be done right now to immediately change this narrative, we do need to start the conversation for future pandemics, as we are very certain that this pandemic will not be the last one. And this event has been made possible, as I mentioned, through One Day Sooner. And it's also, I guess, important to highlight here that One Day Sooner, the African chapter has been working with other cooperating partners. So organizations and institutions that have co-sponsored this event include young emerging scientists from Zambia, the Guinean Medical Society of Guinea, Savana Signatures of Ghana, the Medical Assist Network Trust of Zimbabwe, Work Hard Dream from Kenya, the Ethiopian Center for Disability and Development from Ethiopia, the African Youth Action Network from South Sudan, and the University of Zambia Medical Students Association from Zambia, and then the University of Zimbabwe Postgraduate Center that is from Zimbabwe. And to just proceed now to the event itself, I have the pleasure of introducing our panelists for today. We have a very interesting panel on our hands. So in no particular order, I'm just going to start from Ms. ISMATOU BALDE. Ms. Isma is currently a final year medical student at the University of Cape Town, and she is the president of the Guinean Medical Society, which is a student-led organization advocating for accessible healthcare in Guinea. And she is passionate about women's health and access to healthcare in Africa. Apart from this, in 2020, she was part of a number of committees, among them the University of Cape Town Surgical Society, the University of Cape Town Cardiac Society, and also SCORA, which is a standing committee on sexual and reproductive health, including HIV/AIDS, and also SHALCO, which is a student health and wellness community organization. Finally, she is currently part of the University of Cape Town Global Surgery Student Research Group, and she's also conducting research with the hepatobiliary surgical department at Groote Schuur Hospital. So welcome, Ms. Isma. Okay, then the next one is Dr. Hawanatu Asanatu Barry. Dr. Hawanatu, as the name suggests, is a medical doctor from Sierra Leone who worked with the Ebola task force in 2014 during the outbreak. She is also a current student at the School of Public Health at the University of Ghana doing her postdoctoral work. Among her accolades include her being a 2017 Mandela Washington Fellowship alumna at Arizona State University. She is a medical officer at Aberdeen Women's Center. She's working for the Ministry of Health and Sanitation in Sierra Leone. And also she's the Congress Secretary of the Sierra Leone Medical and Dental Association. And finally, she's also the Assistant Secretary General for the Sierra Leone Medical Women's Association. So welcome, Dr. Hawanatou. And finally, by no way the least, Stephen Manchishi. He holds a Bachelor of Science degree in Biological Sciences from the University of Zambia. Also has a Master of Science degree in Neuron Physiology from Northeast Normal University in China, and is currently completing a PhD in Neuroendocrinology from the University of Cambridge in the United Kingdom. He is interested in basic biological science research with current research interests in neuroendocrine regulation and the reproductive system in mammals. Stephen has also been very interested in promoting STEM in Africa and Zambia in particular. He co-founded and directs a juniors and seniors mentoring network. And also, Stephen served as Zambia's ambassador for the Next Einstein Forum from 2017 to 2019. Welcome, Stephen.
Thank you.
Right, so at this point, we can get into the conversation. So first, I'll allow Isma to take it up.
Hi, can you see my screen?
Yes, please.
Greetings to everyone, and thank you for that great introduction. Thank you to One Day Sooner for inviting me to be a panelist. I'm extremely honored to be a part of such a fantastic panel discussing an important topic, future of medicine in Africa, or rather the future of healthcare in Africa. So you may be thinking, okay, what is the difference? Medicine is the focus and study of science around human biology and caring for patients. Healthcare, to me, tells us more about the science around people and their relationship to health. We measure access, efficiency, and satisfaction. It allows us to describe it. Is it patient-centered? Is it contextual? And so understanding the relationship that people have with health will aid us in understanding medicine in general. As Zachariah said, my name is ISMATOU BALDE. My name is ISMATOU BALDE, and I'm currently a final year medical student at the University of Cape Town, South Africa. I'm originally from Guinea, a small coastal country in West Africa. I'm passionate about a lot of things, and women's health is one of them. Working and caring for women tells you a lot about a society and community. I started my medical journey 6 years ago. I finished high school in 2015 and went straight into medicine with the goal of one day returning back home to Guinea to offer healthcare services in my community. If you speak to anyone from Guinea about their healthcare experience, 99% of them will say the experience was unpleasant. That affects their relationship with health and access to it. In 2018, I had completed my 3rd year of medical school. I went back home to have a better understanding of the health system on the ground. I was in Ignacio Dean Hospital for a week in the surgical department. It's a short time, but nonetheless, I learned and observed so much. I witnessed so many cases that could have been prevented if there was a strong primary healthcare system. I became easily frustrated with this broken system and felt helpless. How could I possibly make a difference in such an unstable system? The answer is always to engage with the community and understand what is needed. We established the Guinean Medical Society, a youth-led organization that advocates for better access to healthcare that is affordable and evidence-based in Guinea. We redefine healthcare in Guinea through leadership, advocacy, and empowering communities. This meant a huge emphasis on health promotion and engaging our members on conversations around social determinants of health. GMS launched in May 2020. To date, we have 122 members, both in health science and other backgrounds, in Guinea and in the diaspora. We successfully organized a COVID-19 response campaign, which included having health promotion material in English and French to educate our community on how to keep themselves safe. We managed to raise enough funds to donate 1,000 hand sanitizers manufactured in Guinea in collaboration with Foundation RBB and the University of Gamal Abdel Nasser in Guinea, and donated 2,500 masks to 5 health facilities in Conakry. We are grateful to the organizations that we worked with that made this possible. At this moment, nothing was truer than the words by Margaret J. Wheatley. There is no power for change greater than a community discovering what it cares about. Our health promotion efforts were aimed at educating our community on the healthcare structure in Guinea, the Ebola crisis and its contribution to the turning point in the health system, and of course, women's health in Guinea. We are currently doing an HIV/AIDS campaign in collaboration with Doctors Without Borders to raise funds for individuals that need treatment in Guinea. And today, we launch our HPV awareness campaign to commemorate HPV Awareness Day. This reflects the future of healthcare in Guinea and Africa too, a healthcare system grounded in a care paradigm, collaborative spirit, and community-centered approach. When I was in Guinea, I felt as though there were too many problems to tackle, and talking about these issues may become overwhelming. There's a quote by Guinean in Yugen that goes like this: I want to talk to you about one of the biggest myths in medicine, and that is the idea that all we need are more medical breakthroughs, and then all our problems will be solved. That is strikingly true. Healthcare is complex, and we need everyone to come to the party. Like many medical students, I like a good party. And even better, I love a good systematic approach to solving a problem or disease. There's no better way for solving African problems than with African solutions. I hope to offer an approach on how we can envision the future of healthcare in Africa, using Guinea as an example. In medicine, we always start with a history. The history has a presenting problem of past medical or surgical history, family history, social history, and a systematic inquiry, followed by an examination, bedside investigations, special investigations, a diagnosis, an assessment, and then a plan. So let's get dissecting. This is history. This is the most important step in getting a diagnosis. In fact, 80% of your diagnosis comes from the history. In the context of Guinea, it is so important to know its history so we can understand the past, realize what is happening in the present, and it will inform us on solutions we can implement for the future. A lot of Guinea's history can be linked to access to healthcare and can give a diagnosis of some of the problems we are facing. Following independence from France in 1958, a number of Guinea's state institutions required urgent rebuilding, especially the healthcare sector. As French nationals quickly departed the country, only a small number of medically trained doctors and nurses remained. Widespread corruption and misappropriation of state funds resulted in decades-long neglect of the Guinean healthcare sector. Guinea has been officially classified by the United Nations Development Programme as one of the least developed countries in the world. In 1987, Guinea adopted the Bamako Initiative, which outlined protocols designed to increase availability of medicines and healthcare services to sub-Saharan Africans. While progress has been made, in particular increasing accessibility to healthcare through community-based programs, both public and private medical facilities in Guinea are badly equipped and fall considerably short of international standards. So now we move on to the past medical history. This usually tells us about any comorbidities patients have or any allergies. In the context of Guinea, we want to know what major events have happened that affect the healthcare system. For example, Ebola. What lessons have we learned and what changes have we made? Another thing it can tell us is the risk we are at and what diseases we are susceptible to due to location and environment. For example, malaria, typhoid, and cholera. Then we move on to family history. This tells us what's happening genetically and if we have risk of developing the same illnesses, and will prompt us to be alert for the development of other diseases. So in this context, we have to ask, how are our neighboring countries doing? Do they have an efficient health system? What are the similarities and differences? What lessons can we learn from them? How can we work together? And are there diseases we need to be worried about? For example, in 2020, Ebola re-emerged in Congo. And just recently, new cases were recorded in Guinea. Should we have increased our surveillance measures? Next, we have social history. This often tells us about patients' habits and how it influences their health. For example, substance use. In this context, we want to understand the socio-political, and economic stability in Guinea. Are there supportive structures, such as mental health services? What is the infrastructure like? Is there job and food security, access to water, sanitation, and hygiene products? So now that we have a differential diagnosis, we want to do an examination to identify what physical signs are evident to confirm this diagnosis. In the examination, we always start with inspection. Observe the system. What does it tell us superficially? Are we generally doing okay? What is happening with our vital signs? What are the parameters that we're using to assess function and improvements in Guinea? And are our social determinants of health stable? We then move on to system-specific examination. How is our public health system? Do we have a reliable screening tools? What are some of the upstream issues that need to be tackled, such as vaccinations and family planning? Now, we want to exclude some diseases, so we end up with one diagnosis, and we want to find a cause. So let's look at our bedside investigations, which accounts for the issues close to home, usually barriers, such as health beliefs and attitudes, cultural restrictions, physical barriers, and poverty. Then we look at special investigations. These are tackling issues on a deeper level: government policy and evidence-based research and protocols, funding, medical insurance policies, and record keeping. After all of this, we need to have a diagnosis because that will inform our plan moving forward. So our diagnosis is that Guinea is a resource-deficient health system. But we want to know, how bad is it? We have to look at literature and data, look at life expectancy, maternal death rates, communicable versus non-communicable diseases, and our literacy levels. Then we need to ask, can we recover in the next 10 years? Or do we need 50 years? So my assessment for our patient, Guinea, is that Guinea is a 62-year-old independent country with a known history of political and economic instability, community mistrust of Western medicine, and poor health facilities, now presenting with a poor primary health and public health system, secondary to a disengaged government, the lack of funding, which all is in keeping with the current state of Guinea, a health system in need of support, stat. So what is our plan? It should always address the biopsychosocial factors in a patient. This biopsychosocial model is an interdisciplinary model that looks at the interconnection between biology, psychology, and socio-environmental factors. In this case, we're going to look at short-term and long-term planning. The short-term plans include community engagement with trained community healthcare workers, establishing a referral system and levels of care, engaging religious leaders, and asking what is the role of traditional healers, accurate and relevant patient education. And then for long-term, we need to look at health policies that are relevant and contextualized, look at national government buy-in, establish health rehabilitation units and train professionals, training programs for health science disciplines, investments in health, a multi-sectoral approach to health, and using technology to improve access. And when all of this is done, we need to counsel on risks. The risk is that you'll have to have some uncomfortable and hard conversations. You will have to step on some toes. And it might fail, but if it does, we try something else. This approach might not work for everyone, but we all want the best for the African healthcare system. So as long as we have that in mind, we will make progress. So in conclusion, the future of healthcare in Africa looks hopeful, but it requires great reflection and dissection. We can use a systematic approach to begin implementing change. The future of healthcare in Africa is community-centered, multi-sectoral, contextual, and holistic. Thank you. And feel free to reach out to us and Guinean Medical Society. Thank you.
Yeah, thank you so much, Isma, for that wonderful presentation. So at this point, we will be moving along to Dr. Hawanatu Barry. As I indicated in my introduction, Dr. Hawanatu was actually one of the frontline health workers during the Ebola outbreak in West Africa. So Dr. Hawanatu, take it up.
Okay. Hello, everyone. Thank you for having me on this platform. It's actually a privilege for us to get young-minded people to talk about Africa and medicine. I'll begin with this first slide. So who I am and what I do. I am currently a public health student at the School of Public Health, University of Ghana in the Population, Family and Reproductive Health Department. I work as a medical officer at the Aberdeen Women's Center, which is under the Ministry of Health and Sanitation. That is a center of excellence that offers maternity services to vulnerable girls and women. We offer fistula treatments to women that have complications of obstetric conditions. We also offer care to sexual and gender-based violence patients. And also we have a program of teenage pregnancy where we look after teenage girls and follow them on until and after delivery. I am currently the Congress Secretary of the Sierra Leone Medical and Dental Association, which is the chief organization of all the doctors in the country that liaise the doctors' welfare with the ministry, and we communicate with the population. As an Assistant Secretary General of the Sierra Leone Medical Women Association, which is an association that was revived 2 years ago after being dormant for over 10 years because of the low number of female doctors graduating from medical school. We are a society of female doctors that have come together to improve on the quality of health care that is being offered to patients with keen interest on sexual and gender-based violence patients. We also mentor young doctors and also medical students that are aspiring to become doctors, and even boys. We try to talk to them to understand how they should they should take care of their adolescent friends, sisters, and the likes. I am a 2017 Mandela Washington Fellow. I did the public management track doing the program. It was on leadership and management. It was for young African professionals to train us in becoming leaders and change makers in the world. As it's known now, Africa, we have a high population of youth, and the future is actually in our hands. So my location, being a Sierra Leonean, I was born, raised, and I work in Sierra Leone, which is a developing country that has been identified and manifested several public health challenges. We have had conflicts of war. We have natural resources. We have diamonds, which is being mined in our country. But unfortunately, the particular area that is being mined, the people are not benefiting from it at all. We have high maternal and infant mortality rates, high infectious disease rates, etc. So this made our country a country of attraction to researchers. There are so many times that people do research from our countries without the Sierra Leoneans being involved. So many research have been done in Sierra Leone without the Sierra Leoneans. But with the trends of things now, the awareness of research and medicine is actually growing. And now we are having doctors that are involving themselves in research and are publishing articles on ways to take care of our country. As a medical student in fifth year, all my desire was just to become a doctor. After doing my obstetrics and gynecological posting, I was stressed out because every day you treat patients for conditions that they go and come back for. You treat children for malaria, they go and come back. You treat them for cholera, they go and come back. Then I became concerned. Then the why question came in, like why? Why should we be treating all these cases and these patients are coming back? That was when I started getting interest in research. So there was an assessment that was done after the free healthcare, which was initiated in 2010 by the president, in order to address the issue of high maternal mortality and infant mortality. To reduce it, he launched the program of the Free Health Initiative. It was a laudable approach, and which to some extent in the first 2 years there was some decrease, but later everything started shooting up. Then the question came onto me again, like why? So is it that providing the care, is that enough? What are we missing? So I was so intrigued that I volunteered to be a data collector on an assessment that was done by that time to assess the Free Healthcare Initiative. Finishing medical school in 2014, we were struck by the endemic of Ebola, which took us all off our feet. You know, just coming out for medical school, you are so afraid of, you are not sure of what you actually know to practically handle humans in your hands. And then there is an outrage of something that nobody understands. There was panic everywhere, but the thought of who will then see these patients, who will then attend to them. If everybody is afraid, everybody runs away, then no one will take care of them. So that made me involved in the work during Ebola. So I was the supervising doctor of one of the teams at the national airport, where we screen patients coming in and out of Ebola, of the country during Ebola outbreak. And then the STRIVE study came up, which is the Sierra Leone trial to introduce a vaccine against Ebola. This study came at the time when Ebola was ongoing. So people were dying at the other side, and there is a trial. And you know, the normal attribute for Africans towards clinical trials, like, what is this? We've never had anything like this being done. People were scared. They were even wondering, are people even going to subscribe to this? But you know, there are people that actually feel like we have to do something as Africans. So then the study came up, and I was part of the study. It was sponsored by CDC, collaborating with the University of Sierra Leone, College of Medicine and Allied Health Sciences, the Ministry of Health and Sanitation, the Department of Health and Human Sciences, and eHealth. It started in 2015 and was finally completed in 2016. This was it was an eye-opener as the first clinical trial to be done in our country, done and led by a Sierra Leonean doctor who is Professor Mohamed Samai. You know, he brought in so many medical students, so many doctors. You know, when you're working with someone that is your own, there was this comfort. People were not that panicked as if, oh, they want to come and insert something on us to kill us, or, you know, all these theories that people have. It wasn't that way. So it was successful. And now I would say at the end of it all, because this trial started in Guinea, the phase 2 and phase 3 was done in Sierra Leone. At the end of it all, now I can say the attitude towards Ebola vaccine coming into our country will not be that negative as compared to before, because we are sure that we took part and we saw the process. For the future of medicine in Africa, I will say we need evidence-based medicine. It has been long that we have been working on what people think, what people have done about us. It's time we take research in our hands. Research will give us the insights and enhance us to create innovative solutions to handle our conditions that are specific to us. We do not need, as Africans, for people from the Western world to come and teach us how to treat malaria, because it's endemic in our country, and we have been having it. They don't have it that much. So why can't we take that in our hands? Because we are not open up to research. We just rely on past resources. So it is actually the limelight, and it should be done now. Gone are the days that, you know, you feel like, oh, as a medical student, I just have to graduate into a doctor and that's it. Everybody's working in isolation. No. Research starts now at an early stage. Once you're in school, when you are doing your ward rounds, you notice you want to assess your treatment that is going on. Why is this patient responding to this treatment and this one is not responding? You know, those are the things that should be triggering in your mind. And now we as Africans, we should start now. Communication with research. If there is no communication, then people will not accept it. You know, there has to be dissemination of the right information. You know, with this advent of COVID-19, because it started with a theory that was saying it was a tussle between the Asian and the Western world and America, it brought a negative thoughts on us. So people are very resistant about the whole thing. We are so much in doubt of the whole existence, which makes it difficult, because that was what led to the total spread. So we have to communicate, and we communicate the right way. Then there has to be an implementation. There is no way that an intervention is going to be done without implementing it, or there is no way that a research is going to be done without implementing. You have to try it. And Africans, we have to be open-minded. If we want to move Africa forward, we want to get our own diagnosis, we want to get our own medication, we want to invent things, then we should be ready and have an open mind to implementation. The other thing that I see in Africa is we have to treat medicine in a system thinking way, not in isolation, looking at health in a broad perspective, both the clinical arm and the public health arm. You know, it's for my country in Sierra Leone, there was a time that it was just, we have the clinicians and we have the public health specialists, no connection between them. That does not yield anything, because if you are working out in the field and the clinician is just treating, then there is no connection. So all of us have to work together, and we have to create the system in a way that if I am sick, I should be very confident to walk into any government hospital and get treated. The same way my nurses should also get into the same hospital and be offered the same service. So we have to think of it in a broad perspective. And then public health. There is no way, you know, especially for us in Africa, we have very fragile health system. Our capacity of health workers is very limited. So for us to be able to support the clinical system that we already have, which has a huge burden already, we have to enforce on public health, because that costs less. We don't have too much doctors, we don't have too much nurses, we don't have too much community health workers. But public health, you practice preventive medicine. You prevent them from coming into the system and overloading it. So if we invest on that, it takes less expenses for us, you know, and then we can be able to understand the reason for recurrence of diseases, understand the reasons why people are not adhering. You know, we have been treating malaria for several years, coming in with every type of intervention. At some point, they are like, okay, now we are bringing the treated nets. And then what? You start giving the nets, and then in that particular area that you have been giving the nets, you have troops of children coming in with malaria, just for you to find out that they have not been sleeping under the net, they are using it for something else. So it only takes public health. People have to go out to the communities to be able to know what's really going on. Infrastructure. So for all of this system to work, there has to be an infrastructure so that it can function in a proper way. We have to have institutions that are in line with it. We have government institutions, we have to have medical hospitals, we have to have medical schools, we have to have nursing schools, you know, we have to have laboratories. We can't be talking about research without having research labs. You know, we have to have all of this in place. Then education is very key. You know, going through school and then graduating with a degree or a master's is not enough. You learn every day. When people are educated, especially for people in the health field, when you are educated, it gives confidence to the population. The public rely on you. The reason why people who are, let's say, people who have money, they go out to the Western world to seek healthcare is because we don't trust the system. We feel like, oh, their own level of education is higher. We are not exposed to that much. You can't treat that. So we need to train. We need to be training our health workers continually, our research people continually, because even if we don't train them, then there is no way they can be able to offer their service. But if we train our people, then the populace will be very reliant on them. You know, with resources, we have to, there is no way we can do all of this without resources. When I say resources, I mean human resource, financing. There has to be prioritization of financing, especially at the national level, because that is what it is. Health budget allocations. It doesn't have to be last on the list, because it is a healthy nation that makes a nation works well. If the health system is weak, if medicine is poor in the country, you will always spend all the finances in the country trying to fix these diseases, trying to fix this system, which yields to nothing. So a chunk of the national budget should be allocated to health and not in the minority.
I hope you can all hear me well. Thank you. Thank you, Wande Sona, for inviting me to be part of this meeting. It's a very humbling opportunity. And thank you for the introduction as well. I won't go through that because you've ably introduced me. And I'm glad that two speakers have spoken ahead of me, and they've mostly preempted most of what I wanted to say, but that's perfectly fine. I'm just going to reiterate some of the points that have been shared, especially by the most recent previous speaker, but looking at it from the perspective of a basic scientist rather than a medical doctor. So I just did a Google search a few hours ago, looking at the research output from Africa, and I found two articles. Both of them are written in 2018, and I don't think anything has changed much. But statistics show that only 1%, 1 to 2% of research output world over comes from Africa, which to me is quite disappointing. But much as I'm disappointed, I'm very aware that this is actually a true picture from the interactions I've had back here in Africa and the few stints I've had abroad, which is an opportunity I really appreciate. So I'll just share my thoughts of why I think we are contributing only 1 to 2%. I think one of the reasons is that we as Africans, and I'm trying to talk here generally as Africa as a whole, I'm not pinpointing any country in particular. I'm from Zambia. I am in Zambia, and I'm not, when I'm saying this, I'm not particularly saying this about Zambia, but I'm saying as Africa as a whole with the interactions I've had with fellow Africans. I think we have developed a dependency and a comfort zone mentality. We kind of think that the West will do the research for us and donate the findings, which is what we've seen in most of the areas. We've kind of got to a comfort zone where we think, like we've apportioned responsibilities. We think the West is meant to do the research, whereas we just remain as consumers of the research. So we let them donate the findings, we let them donate the funds of almost everything. We seem to be comfortable in this particular zone, which is one of the reasons why I think we're only contributing 1 to 2%. And I mean, there are many reasons why this is happening. Most of it goes down to funding and management. And we also seem to be okay as Africans to do mediocre things. We say, when we go into research, we're not really expecting high value impact results. And whatever we get, we're kind of in the comfort zone. We say, this is fine because, I mean, we're African, so what do you expect? If I get into a research, I might not employ the best research methodologies, for example, but I expect the world around me or my peers around to accept what I get, and I get away with just saying because I'm African, I'm in Zambia, I'm in Africa. So I kind of expect you to accept what I get, which is mediocre. And that's one of the reasons why we're not exporting some of the research findings, because they're really mediocre and we are sadly comfortable with it. And as governments, we seem to think science is an unnecessary luxury. So we have other pressing issues. This is quite debatable. Yes, I agree. We have other pressing issues. We have to feed ourselves. We have to feed our people. And funding science is really not something that we take as a first priority. And just like Hawanato said, this leads us to depend on external research, which is kind of disadvantaging us because we cannot use solutions from the West to tackle problems of our continent. The second reason, I think, is because of sensationalism and conspiracy theories, and the year 2020 and 2021 has really brought this out. As Africans, we seem to think that the scientists are up to no good, they're up to kill us. And we're not really interested in science because we kind of don't believe in science. And again, like I said from the beginning, this is mostly coming down to the managers, the people that are allocating resources. So they don't really see science as a priority. And talking about Zambia, we have had this before where people have debated about genetically modified organisms or products. This debate has really been there for quite a long time. I know it's not directly related to medicine or the topic that we're talking about now, but I'm just giving that as an example where we don't seem to have trust in science as Africans, and this is one of the reasons why we're not prioritizing it. We also, again, back to my first point where we seem to be in the comfort zone. We think we have our own way of doing things, and science is not really our indigenous way. So much as we want to stick to our indigenous ways and resist change, then that prevents us from contributing a larger chunk of science to the global world. The other context, I think, is because Africa is one of the highly spiritual continents, and because of spiritualism, we kind of prioritize spiritualism at the expense of scientific methodologies. So some people kind of think that science is the opposite of religion, which is not really the case. You can be a very good scientist as well as a very good religious person. But I think this is something that has not percolated into the minds of many African managers at government level. So they don't really want to prioritize science at the expense of religion. It's very easy for me to convince someone about a religious fact in inverted commas, as opposed to a scientific fact, because we've kind of been brainwashed as Africans. And in that same line, we think God will take care of things supernaturally rather than us ourselves doing the work. I think things are changing, and I think we are doing things to kind of improve the status quo. Just like the previous speaker said, we need to fund and stock up our research facilities. We cannot talk about research if you don't have facilities. It's high time we own our own future and embrace evidence-based policy directions. And I know that Africa is kind of going in that direction already. I've seen a lot of small organizations, emerging scientists all over the continent, Nigeria, Kenya, and other countries that are really coming up, and I think this is the direction to go. And we also need to encourage collaboration. At this point, I'm talking about collaboration both within our continent. So we need to encourage international collaboration within our continent, and also north to south collaboration. We can collaborate with Europe, with America, and other developed countries, but with equal opportunities. UNZAMEDSA did say that previously in Sierra Leone, they had research that did not really involve the local people, and that's really a problem. So we need to have equal opportunities rather than just being used as guinea pigs. So when we engage in research collaboration, we need to go in as equal partners. Yeah, like I said, we also need to embrace regional collaboration within regional blocks in Africa. We have SADC, we have ECOWAS, we have East Africa. Within this is what the Western world is doing, and they seem to be succeeding with this approach. We also need to work together as clinical scientists and basic scientists. This is in addition to what UNZAMEDSA said about clinicians and people in the field, but we need to bring in basic scientists as well. If we talk about medicine, we talk about drug discovery, it all starts from basic research. We talk about vaccine development, it starts from basic research. All these have to be done from the very basic. It's done at cellular level, then you go into animal models before you go into clinical trials. So it all starts from basic research, and if we leave out basic scientists, we're not really going to go very far in our goal to bring about current trends in medicine. We also need to publicize and recognize research output. This is going to encourage more vibrant researchers to venture into research and report their findings. So we can do this by regular seminars and workshops and public engagements. This is one of the things that is going to encourage, like what we are doing now. We should encourage a lot of this, and I know it's already happening in many African countries and at different levels. So like I said, we're already doing some of these things. We should just encourage each other and continue. This is probably going to lead us to current trends in medicine. For example, we've had the launch of the African Scientific Journal, which is a good step. And we have an opportunity as Africans to publish our research in our own homegrown journal, where it's an international journal where all Africans have access. As a way of publicizing and rewarding research output in our workplaces, this is a double-edged sword, but we need to encourage journal publications as a basis for promotion at work. I'm saying it's a double-edged sword because if resources are not provided to us to do the research and publish, it's going to disadvantage us. So if we're going to stick to this appreciation of research output and promotion based on that, our managers or the policymakers, the government should provide resources and then use this as a basis for promotion and rewarding employees. So in conclusion, I think the future of medicine in Africa and elsewhere is anchored on basic science research. Unfortunately, basic science is not a priority funding area in Africa. And until the research environment is improved, we might continue just trying to catch up with the West, and this will be in vain. We'll talk more in the Q&A. Thank you.
Okay, thanks a lot, Stephen. Thanks, Savana, too. So just to reel in the conversation, I think all of you have spoken of something that I think is very interesting. So Isma, you mentioned something that most of the practice of medicine in Africa seems to be based on history, if I may put it that way, because mostly when people are going to medical school, what they do is get books which were written some years back, they read, memorize, so that they can pass exams and ultimately end up in the hospitals practicing medicine. And then Dr. Hawanath, you mentioned that what we need in Africa is evidence-based medical practice. And now Stephen has just highlighted the need for scientific research as a precursor for the correct practice of medicine. We need to conduct research first before we understand what needs to be the intervention in terms of medical practice. So I'm just going to throw a question to you, to the audience. If anyone has a question, please just type it in the chat. We'll be able to pick it up. But so my question to any of you who cares to respond is, looking at Africa as a continent, we have seen the many areas where we have weakness in terms of our investment in research, and also the lack of policy to guide, let's say, spending in part of governments, and the willingness also on the part of Africans to actually participate in trials, like it has been highlighted already. What would you imagine would be the first step to correcting this current state of affairs? Just the first step. Maybe we should start with Stephen, since you are doing your research now.
Well, I think the problem, the bigger problem is that we have people managing us who are not really well versed in these things. And most of the government or the leaders in many countries are either social scientists or not scientists at all. So probably we shouldn't look at a distance. We should get ourselves involved in policy making and drive the evidence-based policy direction ourselves. So we shouldn't watch from afar, we shouldn't watch from the terraces, but get involved as much as we can in driving policy at the highest level. That's what I think we should do.
Yeah, thank you. Dr. Hawanath, do you care to weigh in?
Like I said, yes, of course, we need involvement for us to be able to accept research and all it entails in Africa. And then we need education, because getting involved, you have to be educated. If you don't know what you're going to be involved in, you are not full to that capacity, you can't handle it. So we need to capacitate ourselves and get involved.
And Isma, do you have anything to add to that?
I think I share the same sentiments as the previous speakers. And I think Stephen mentioned that more African researchers, because that means that we are in control of our own narratives in Africa. And that's an important point. And I think the topic the word that Dr. Hawanath was leaning towards is having more clinician scientists, not just a doctor, not just a scientist, but bringing those two things together and understanding what happens in science affects what happens in clinics and the clinical setting. So,
yeah, I think so. There's a thought here that looking at the panel, the way it is, I think it's fair to say all of you are, I would say, young, and we're looking at the future of medicine. So we are looking at the young people in Africa trying to change this narrative that currently burdens Africa. So when we think of the future of African medicine, do you imagine that we can improve? all factors considered, do you imagine that there is a way that we can actually improve the practice of medicine in Africa?
Can I come in? Yes.
Please.
Yes, I think we can improve, and I think this is even the first step. By one day sooner, bringing young people on board, identifying researchers and medical practitioners, bringing like minds together, will be able.
Thank you for that.
Yeah, I agree. I think in order to improve, we need to involve our communities in both the decision-making and the problem-solving phases. I think oftentimes we leave them out, and then we have the solution that we now bring into a community and expect them to engage with. So I think from the get-go, our community should be involved, and collaboration is very important to improving healthcare in Africa, as well as having a multidisciplinary team. And lastly, making healthcare contextual, because we're taking research and evidence from countries that have a different context to countries in Africa.
Okay, and another thought or another concern is that even in situations where there is research which is supposed to be coming up, Africans tend to get afraid to participate in this research, especially as trial participants, where they volunteer to be, let's say, we're having COVID-19 trials, and then people go and volunteer to receive the injections. Very few Africans would be willing to take that step. What do you think is the reason as we wind up?
As you guys are still unmuting your mics, I'll start my thought on this. I think it's communication, because there are two opposing views, right? There are people that are anti-vaccinations. There are people that are pro-conspiracy theories, and then there's another group of scientists that think this is a noble cause which needs to be followed. So it depends on who speaks to the people, who speaks to the public. So the public are out there to listen. So as long as we who seem to have a different view do not reach out, do not engage the public and tell them about what vaccinations are, about what trials are, about the benefits of their trials, they'll get it from someone else. And these anti-vaxxers are out there bombarding the population with all sorts of information. And as long as we don't counter their information, they'll take the day. So I think it's more about communication of our research findings, about our ideas, and just bring ourselves to the front rather than always looking from the terraces and coming back.
Thank you for that.
Yeah, and I agree. I mean, I don't blame our communities for having this mistrust in vaccines and Western medicine, because history shows us that medicine historically, what it did to the people of Africa wasn't very positive. So once again, it's engaging with communities and saying, okay, what are the fears? Let's talk about those fears, and showing them the benefits of that and how it has changed from what they know until now, what developments we've made. So I think at the end, the core is engaging with communities and making sure that we're speaking the same language as our communities, because that's the only way they'll understand us.
Thank you so much for that. And we are coming to the end of our session, but just to perhaps wrap this up. So the first takeaway from this is that as leaders on the continent, government, civic or traditional, they have a responsibility to spread the correct message around diseases, around research, and also in promoting this culture of research on the continent. As people have already spoken here, Africa has become, a ground for receiving donations, and this is by no means sustainable. And as a method of trying to encourage and promote research on the continent, we actually need Africans to do research. That way there will be more trust in the therapeutics that are produced, in the therapeutics that are being produced to the people. One day SUNA does organize more and more events like this one. So on the 18th of March, we'll be having another such kind of panel discussion on global equity and COVID-19 vaccines, or vaccine internationalism. So do look out for that Eventbrite. My name has been Zechariah Kafuko. I'm the African Chapter Manager for One Day Sooner. Thank you so much to you, Stephen, to ISMA and ISMATOU and the One Day team, and to the audience for sticking around with us through this. Hope to see you next time. Thank you.
Thank you.
Thank you.